source setting.
Thank you very much. It's a great pleasure to be at this meeting. And all I can say is I'm super impressed, super impressed. Thank you, Dr. Simon. Thank you, all of you who've organized this meeting. And it is really so impressive. I'm so proud of your young people. So with those words, let me start talking about developing automated assays for early detection and monitoring of disease burden in low and middle income countries. And today I'll touch upon breast, colon, and prostate cancer. So these are some of my disclosures. And so what's the excitement about? So as all of you have heard about precision medicine, all of you have heard about nucleotide sequencing and finding mutations in either circulating tumor DNA or in the tissue itself. But many of you may not have heard about another change that takes place very, very commonly in cancer, and that is the hypermethylation of genes. And as a result of the hypermethylation, the gene expression is shut off. But the beauty about methylation is that it is reversible, it is an epigenetic change. And so in stretches of DNA which have high CG content, a methyl group arrives at the C, and as a result of having a cloud of methylation in an area, particularly the promoter of the gene expression is completely silenced. So it is another way of completely losing the expression of a protein as a result of hypermethylation of DNA. Now, this provides us a very good opportunity to develop markers because it is DNA-based, it is extremely stable, and it is activated very, very early in disease. So hypermethylated genes are commonly observed in breast cancer and other cancers, and hypermethylated genes are potent markers for the presence of disease. We have worked on this for nearly 25 years, and after all of that basic research was done, my question was, where are we going to apply it, and how are we going to make a difference to the world? And so first, I must emphasize for any of these studies to have a strong omics team. And our team has been going on since 2007, and the essential elements of it are that you should have a medical oncologist on your team so that they are able to tell you what are the problems that are being seen in the clinic and how you can address it. We have in the middle a bioinformatician and a biostatistician, because without them, there's no point in starting a study without powering it properly, without designing it properly. Similarly, Kala Viswanathan is our epidemiologist, and she helps us then to put all of our findings in the context of what the other clinical characteristics of the patient is. And Chris Umbrecht is in charge of our database. Without a good database and without proper curation of that database and auditing, all of your results are going to be unreliable. So why go global? We know that the magnitude of the problem is great, that the global burden of breast cancer is increasing, and breast cancer is the second most common cancer in the world, and it affects women everywhere. So what is the problem that we are facing? The problem is that the breast cancer outcome is different in low and middle income countries. So incidence in the blue bars says that the Western countries have a very high incidence of breast cancer, and the red bars say what the mortality is. And as you go down the line, you see that actually the low and middle income countries have a very low incidence of breast cancer, but the size of the red bar doesn't change. Mortality is the same. So this is a big problem. So that is what's shown here. So what are the reasons for this disparity? Low and middle income countries suffer 50% of the health burden due to breast cancer. And why is that so? Because in most countries, population mammography screening is simply absent, and it is not accessible, and the women present with palpable breast lesions. Delays in referral into tertiary hospitals occur. There are insufficient number of pathologists to provide a timely diagnosis. So the fact of the matter is mammography is also impractical due to costs and difficulty in implementation, and also the ability to keep those mammographic machines in order. So the introduction to South Africa for me came through our radiologist, Susan Harvey, shown on the left, who was doing a lot of ultrasound screening and training people to do ultrasound screening so that they could detect these cancers earlier. And on the right, I show Maureen Joffe. She's a real superwoman, and she's the one who has been able to implement our studies in this distant land. So off we went to South Africa to find out what is the lay of the land, what are the patients they are seeing, what is the infrastructure. And in South Africa, the Chris Hani Baragwanath Hospital is in Gauteng province. It's a very large hospital. It really serves 25 million people, most populous and a very poor province. 10,000 patients per day are seen, and nearly 200 to 300 breast cancer on the single clinic day each week. So our vision is the problem, define the problem. There's an urgent need for innovative solutions to prioritize high-risk lesions for pathology review. We are not saying we are going to be diagnosing the lesions. We are saying push the women who need the care to the front of the line so that they can be looked at, while the women with benign lesions we can take your time. The solution is to develop a fast, automated cancer detection assay to provide accurate identification of the lesion as malignant or benign. So what is the final goal? The test should enable rapid prioritization of patients with suspected cancer for further pathologic evaluation and care at a regional care center. So our steps, I'm going to go through this very fast because this is done for every cancer pretty much in the same framework. Step one is discovery by looking at the large databases available to us now. In silico, finding out the best markers that we can use to detect a particular cancer, at the same time having great specificity. That is, the normal tissue should not have those markers. So we identified a 10-gene panel that distinguishes between malignant and benign breast disease with high sensitivity and specificity, and we aim for an area under the curve always of over 0.9. The same 10-gene panel of methylated genes performs equally well in 3 different ethnic populations. And how do we do this? We do this by examining FFP specimens from 3 different countries, 3 different ethnicities. So what we are looking for is a single panel that will be useful throughout the world. And how does this look like? What you see here is a histogram. I want to explain this. At the bottom are lined the 10 genes that we look at. Each gene is marked by a different color. So each gene, as you see in the tallest bar here, that particular patient has all of these genes methylated. Whereas as you come down, you might see just 1 gene, 2 gene, etc. Therefore, this 10-gene panel is able to cover the heterogeneity of breast cancer that is seen throughout the world. And what you see very clearly is the box plot that shows that there is a very distinct difference between the methylation in tumor tissue compared to normal. And on the right is an area under the curve, the ROC curve, and that shows that this particular assay worked at AUC of 0.96 with sensitivity of 96% and a specificity of 90%. This was a pilot study, so this was very good preliminary data for us to begin to think about what do we do with this assay. So we automated it along with Safid, a company, and what we show here is that FNA from a palpable breast lesion on a slide is put into the tube, just shaken. It has lysis buffer in it, and you put that into a single cartridge that will convert the DNA with bisulfite. This is an essential step in studying hypermethylated genes. And then that material goes into 2 cartridges, and within about 5 hours, you are able to tell whether a patient's material is benign or malignant. So the goal of our current research, and so we got funded by the NCI with a very large grant called the Industrial Academic Partnership. So the goal of that is to develop an inexpensive, single cartridge, automated methylated marker assay on FNA. Why single? Because that is all we can afford in the low and middle income countries. And so our goal was to negate the use of the methylation cartridge, and to negate the use of 2 cartridges for the genes, we will do the assay with just 1 cartridge. And did we succeed? Indeed, this is the study that is going on right now, and this is a prospective case control clinical study that was initiated in South Africa, and the assay validation was 120 patients, and clinical utility will be tested on 560. And the design is that we will expect more than 90% specificity and sensitivity, and the numbers were calculated based on that. What did it look like? So here are some of the touch preps of the FNA. On top is unstained, at the bottom is stained. 4 slides are stained, 4 slides are unstained, and so the cytologist is able to look at the stained slides. We get all 8 of it at the end of, of their analysis. The accrual has been wonderful. We have 5 years in this grant. We are not even in the 3rd year, but we have already accrued all of the patients we need for the study. We have only 120 or 200 that have to be shipped to us, and this is fantastic rate of accrual and the way the study is moving. We do very, very strict intra-assay and inter-operator variability to check, and we found that our ICC, or intra-class coefficient, was 0.91 when the same assay was done 4 times. And when 2 different people do it, which is the inter-operator, you can see that the concordance between the operators was 0.986. So these assay validation steps are extremely important before you go on to clinical validation. So this is another assay validation step where we have compared what the level of methylation in invasive ductal carcinoma is versus benign. And as you can see, we were able to really achieve very high levels of specificity and of the ROC AUC. So the advantages of the Gene Expert cartridge system, it's a simplified assay, data analysis and interpretation are all automated so that the operator has nothing really in terms of input. So it's very easily done by a trained operator. This newly developed methylation cartridge could be easily adapted for detection of other cancers, and a positive assay would lead to expedited pathology and to rapid treatment. So our vision is that we would combine ultrasound with AI, which is going on right now, and be able to detect a lesion in a screening setting. We would take an FNA of that lesion, put it through this assay, which only takes 3 hours now, and be able to say whether it is positive or negative. If it is a positive assay, there is another cartridge that does ER, PR, HER2 right there on the spot, 1.5 hours, and as a result, we will be able to send this patient for expedited pathology and expedited care. Why will this approach work? Because Cepheid has more than 30,000 instruments in the centers throughout the world. They are the foremost TB testing machine in most of Africa. And therefore, this cartridge just fits into the same machine, and there is a pre-existing familiarity with this particular cartridge. Mini battery-operated units are also available. What will be the impact? Millions of women will be screened by ultrasound, automated diagnosis and subtyping will be performed within hours of arrival at the clinic, and treatment would start rapidly. At least the woman, if she says, I'm not coming back, would go with a handful of tamoxifen pills, and just by this act, if we are able to keep that up, we will be able to save millions of women. So screening and timely diagnosis is key to reducing mortality due to breast cancer. In my remaining time, I'd like to also show you how well this cartridge adapts itself to the detection of other cancers. So cancer-specific DNA methylation provides a powerful cancer detection markers. So would you please go back to the show mode? Oh, you're okay here. Okay. So the new cancer cases and deaths for common cancers in 2020, this has already been covered by Susanna. Large numbers of lung, prostate, colon, rectal, and cervix uterine. I will show you 2 examples here. Automated detection of methylated markers in plasma in patients with colorectal cancer. So we would like to develop a cell-free circulating methylated DNA assay in the Gene Expert cartridge. It takes only 1 milliliter of plasma, and performed assay validation in blood from patients undergoing colonoscopy for chronic GI symptoms. 70% of these patients are benign. They just have chronic GI symptoms, whereas 20% are malignant. So can our assay replace colonoscopy for screening for the presence of GI cancers in places that can ill afford colonoscopy? So I show you the results of our pilot assay, very, very clean. As you can see on the left, normal plasma has practically no background, whereas on the right, we are able to see every single patient's plasma in the cancer setting. Some of them are low, some of them are high, but they are all detectable. So this assay performed with a ROC AUC of 0.996 with 95% sensitivity and 100% specificity. And another example is the prostate cancer. We did discovery in TCGA databases, we did marker selection, and now are doing the lab assay validation. So this is a promising 10-gene panel. This is really amazing. This is all in FFP specimens from one country. This is South Africa. We've done it in Taiwan as well as in the US. And what you can see is benign has very, very low methylation, whereas cancers have very highly detectable methylation. And here the AUC was 1.0, 0.995 with a threshold of 51 cumulative methylation units with a sensitivity of 97% and a specificity of 95%. So this is early in the game. We will now look at blood to see whether we are able to detect the same markers and with what efficiency. And this is just a teaser in terms of the early data. Methylated markers may distinguish between low-grade and high-grade prostate cancer. We took 2 of the 10 methylated markers and combined with age over 55, and we are able to distinguish between high-grade and low-grade with an area under the curve of 0.79. When we do this in Taiwan and in the US, we are able to achieve up to 0.9 AUC-ROC for distinguishing between these two types of cancers. When we ask our oncologists what is the big question in prostate cancer, this is what they point to. They're not particular about detecting prostate cancer, but they're very particular about wanting to know whether they should treat or wait and watch. So for this, as you can see here, we achieved an area under the curve 0.792, and with a p-value of less than 0.001, but with the small set, controls are 36, that is low grade, and the high grade patients were 57. But we are consistently getting similar results in both tissues from Taiwan as well as from the US. So the conclusions to my talk are clinical validation is ongoing in South Africa for detecting breast cancer using fine needle aspirates. Why? Because all of these women come with palpable lesions. So it's so easy to just pinch the lesion, put the needle in, and take out the fluid for the analysis. But as time goes on, we are hoping that this would now become less and less visible lesions, that the ultrasound screening with AI combination will really begin to get these women at much earlier stages so that the tumors are treatable. And when that happens, we will be able to use fine needle aspiration as well. But as the tumors get to be less than 0.5 millimeters, it's practically impossible. And then we have also developed a blood test for those situations. In Nigeria, we are doing for detecting CRC among women with chronic GI bleeding and other symptoms who are undergoing colonoscopy. As I said, 70% of these are benign, only 30% are cancer. And other cancers in the pipeline are to detect high-risk lesions of cervical cancer, which we have done in a pilot study of 250 women from South Africa with great success. And will we be able to really separate out the cancers and the high-grade cells from the low-grade squamous intraepithelial lesions so that we know who to treat and who not to treat. Right now, a lot of non-specific treatment is going on based upon HPV, but we know that HPV positivity is really present in a small fraction. Tumors are present in a small fraction of HPV positive patients. So a lot of effort is going for waste. So prostate cancer, a test in blood to detect prostate cancer in the low and middle income countries where there is absolutely no prostate cancer screening. A blood test to distinguish low-grade and high-grade prostate cancer, and to monitor the response of metastatic prostate cancer to therapy. This is an area that is of great interest to our oncologists at Johns Hopkins. So we are now following patients as they undergo novel therapies to find out whether our blood test is able to say whether therapy is working or not working. When it is working, the methylation markers go down. When it is not working, it goes up. We have shown this in studies, both assay validation as well as clinical validation in breast cancer patients. We monitor the response to metastatic prostate cancer and detect disease recurrence. So these are all our goals, and in the next meeting, perhaps I can give you an update of what's going on. Nothing happens in a vacuum. We have a large study team, our own laboratory. Young people have contributed a great deal to this work, and we have the biostatistics, the people in the medical oncology, our coordinators who run these studies and keep our protocols all up to date. In South Africa, a very, very able team, in Vietnam in National Cancer Hospital, as well as in Ile-Ife in Nigeria. And without the funding, we cannot do anything. The NIH has been very generous, as has DOD. Thank you very much.